Okay. Hi, everybody. We're just going to let people come in slowly. I assume everybody can hear me. Um, we'll give people a few minutes, but I'll just start our usual introduction. So, thank you for joining us. I'm Ellie, co-director of DIAG, Democrats for an Informed Approach to Gender. DIAG is a 501c3 nonprofit organization of lifelong Democratic voters working to depoliticize and shed light on the ideologically driven medical scandal and associated harms that have resulted from the adoption of gender ideology. We're building a movement to shift the prevailing narrative around the experimental, dangerous medical practices that comprise sex trait modification, euphemistically known as gender affirming care, and to clear the path for a safer, saner, evidence based response to gender distress. Please visit our website at diag.org. That's di-ag.org. Please also check out please also check out our merch store. And if you'd like to help us continue and expand the work we're doing, please hit the donate button. DIAG believes in the liberal value of free speech and open discussion, which is part of why we host these spaces, to invite conversation on topics that have been left out of the public discourse. The opinions expressed by our guests are not necessarily the opinions of our organization. Okay. So today we welcome Dr. Eithan Haim, who exposed with severe consequences for his life and career that despite publicly declaring in March 2022 that it would no longer provide pediatric sex trait modification services, Texas Children's Hospital was secretly continuing gender transition treatments on minors, including hormonal intervention on patients as young as 11 years old. If you're not familiar with Dr. Haim's story, yesterday we posted the free press article that details his experience and his interview on the Gender a Wider Lens podcast. So I recommend you check those resources. We're not going to get into that background today because I think most people are familiar with his history. Before we get into our discussion, I'd like to say a few words about a comment we received from a supporter who objected to DIAG platforming Dr. Haim as an example of people who are, quote, hostile to everything Democrats believe in. We appreciate feedback from our supporters and we take feedback very seriously. So we didn't want to just ignore this, and we did respond. As I stated, DIAG believes in classical liberal principles, and that includes civil discourse, even with those with differing views. Also, identifying shared values and working across the aisle to advance common goals, which is how we make meaningful progress and help ensure lasting change. As I also stated, DIAG seeks to depoliticize the narrative around gender medicine and gender ideology because framing our concerns as political has been a devastatingly effective tactic. Any opposition to this belief system has been successfully dismissed simply by being characterized as right wing, purely because Democrats are expected to reject out of hand anything that comes from Republicans. And as we said in our response to this supporter, certainly in terms of this issue, if there is any group that is hostile to everything Democrats once stood for, it is our own party. As with all of our guests, we invited Dr. Haim because we felt he had experiences that would add to our understanding of the gender affirming landscape, and we look forward to hearing his perspective tonight. As usual, we'll leave time at the end for questions from our listeners, so please hold off requesting to speak until then. And as always, we welcome and expect respectful dialogue. So let's get started here. First, I have usually I do prepare for these spaces by doing some background research, and then I prepare questions. And the number of questions I have for Dr. Haim is so long today that I don't think there's any way we'll get through them and also um, leave time for questions. So I'm going to breeze through these as quickly as possible. First, welcome, Eithan. Thank you for joining us. We're happy to have you here.
Yeah, thank you so much for having me on. Can you guys hear me okay?
Yeah, we hear you just fine.
Cool. Yeah, no, it's a privilege. It's thank all of you for joining and taking your time to listen.
Yeah. So first, before we dive into my millions of questions, you know, I don't know whether you have any updates on the HHS case against you that you'd like to share, or if you just want to move on.
Well, yeah, it's coming from the Department of Justice and the FBI. And we are set to go to trial in late October. We're having our first baby October 8th, and we start the trial about like a week after that. And we can't get into the specifics of the case exactly, but the more the further we get into it, the more I realize how totally insane it is, and it just kind of shows why um, I, especially now looking back, if I would have done anything else, it would have been the biggest regret of my life because to let these people get away with this is unconscionable. To think what they've done and how they've weaponized their authority to go after to pursue this case.
And yeah, that's coming up soon. I'm amazed at how quickly this has all moved. And it one thing that maybe you we should go back and mention is the fact that the program did then um, it did shut down right after this. Is that correct?
Well, yeah, within the day after our story came out, the Texas Senate voted to pass SB 14 with bipartisan support, and SB 14 was the law that would ban these gender interventions for children. So within 24 hours of our story coming out, the conduct we exposed became illegal. And I would argue that it's always been illegal. That this it's kind of earned itself a cutout with the Overton window, but given the modern politics, it was able to work its way into our society through like this kind of political exception.
Yeah, 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 exactly. A strange political exception. And when you talked in the beginning, when you said that the longer that you know, deal with your case, and the more that you see what's happening, the crazier it 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 all seems, which I think mirrors this ideology. In the beginning, there's this period of kind of destabilization that I think people get into, where it's like, well, this doesn't sound right, or gender affirming care, this doesn't sound right, but I should think this is rational. This is, a responsible body that I should respect. But then the longer it goes on, you just more and more just cannot make sense of this stuff. There is no making sense of it.
Yeah, and I
So
think that plays a big role with this case too, because for so many people, the perception of the United States justice system is where of course there are its downsides where the justice system makes mistakes, but for the most part, I grew up having faith in the justice system that they went after people who were guilty. People did not weaponize their authority to go after innocent people for political reasons. And luckily, by the time they showed up to my door, I had seen enough cases where the Department of Justice had become weaponized against other people, where I knew what was happening to me, that this is, these things I read about in the news that, I had found myself inside the story.
yeah, it's a shocker, but reality sets in and you move forward. So I'm going to dive into questions with you, um, which, what I'm excited about is it's so rare that we get to talk to clinicians about what's happening and get that perspective. And so, we'll be talking to you tonight. We are, I don't want to announce it, but we're tentatively um, set up to have some other clinicians on spaces coming up. So this is a great opportunity for us. So I assume that there's a certain mindset that you have to have as a surgeon because, you have to be okay with cutting into a body, which obviously is not something that just anyone would feel comfortable doing. So you have to have incredible confidence. You have to believe that what you're doing is absolutely going to improve a patient's life because you're causing damage. You are damaging structures. So, can you talk just a little bit about what motivates someone to become a surgeon and what common traits you see in your peers?
Yeah, so it's an interesting question, I think, and it goes so much to help answer the question about why it is what they're doing with these gender interventions. Why is that so wrong? So, the reason I went into surgery is because I would consider myself a relatively like simple-minded person. Like if there's a problem, I want it to be tangible. I want to be able to fix it. I want to address something that will actually improve someone's life. And there was something about, human physiology and anatomy and these surgical problems that just kind of made sense to me. So, like, as a general surgeon, you deal with hernias, gallbladders. I work in a really small town, so we do a really wide breadth of cases. So, like, colon cancer, skin cancer, foregut with like hiatal hernias, pretty complex cases. But all these are very specific problems that you can define. And the important thing about the mindset of a surgeon is that there's a common misconception that people think that like surgeons are um, kind of inhuman for our ability to operate on people, and that there's some component where there's like this kind of psychopathic narcissist in the background. But I would say that's the exact opposite. Every surgeon I've ever worked with has always had a huge focus on the dignity of the person they're operating on. And the reason is because when something goes wrong, you have to look that person in the eyes afterwards and see their suffering and know that you were the one who caused that suffering. And even when everything goes perfectly, sometimes that is a result that comes about. And that's very painful. So when we take someone to an operating room, we go through this process of diagnosis, right? Where, like today, I had clinic. Someone comes into my clinic and they have a problem, and I have to ask them questions, get an idea of what that problem is. I have to do an exam, which helps narrow that problem. So if it's in a certain part of the abdomen, if it's a certain nature, like if it's a sharp shooting pain versus a dull achy pain, that's a little bit different. But then I have to use more diagnostic testing to very specifically identify what I think the problem is. And if I have a really good idea of what that problem is, then I feel confident enough to say, I believe this is your issue. These are causing your symptoms for this reason. And I explain it to them in really simple terms. Like if you have a gallbladder that's blocked up from stones, it can't empty. The pressure builds up. It causes pain to your liver and your abdominal wall, and that's why you have pain in your right upper quadrant, your shoulder. And you explain how when you remove the gallbladder, it's going to remove this problem. But you also have to explain that things can go wrong, that there's risks. But the only reason that the decision is justified is because we have enough information to justify the risks that the patient is going to be better after surgery than they were before. So this year alone, I've probably done like maybe 320 cases. And it was only in one of those cases that the pathology I was going after was not there, which, and that happens. And this was a case that it was not unexpected. And that's not unique for me. I mean, that's kind of what it should be for most surgeons. When they take you to the operating room, they should have they should be right the vast majority of the time. And if they aren't, that's a big problem.
And s yeah, well, we'll we'll talk a little bit about how that differs from the kind of surgeries we're seeing associated with this ideology. But, you hear about this the God complex with clinicians. This idea that you are kind of above most mortal men, that you can change. You're charged with doing this incredible work, and you're infallible. um is that something that you see? Is that myth? Is that a thing you see in fellow surgeons?
Yeah, I would say I've never seen it before because it's like an anti-God complex. Like, surgeons by nature are very superstitious because we understand that the space that we operate in, we have to abide by laws that exist outside of our control. So we never have to be too confident. Like, we never say like, "Oh yeah, this is just a gallbladder." That's like the last thing you'll ever hear come out of my mouth. Because, there was one time where we thought, "Oh, this is just a toe amputation." 2 hours later and like a liter of blood loss, you know, it's you learn your lesson. But the the surgeons, every surgeon I've worked with, it's the exact opposite. Because the profession is humbling by nature, and the most dangerous thing is if you have a surgeon who believes that they're beyond that, that they are the ones writing the laws of biological reality, and that the complications that happen afterward are all in the service of something greater. And if they're driven by an ideology, that's when things become very, very dangerous. And so far, our profession has done a good job at weeding these people out. But as I'm sure all of you can come to understand, that's quickly changing.
Yeah, yeah, yes, quickly. I'm going to say we have one request to speak, and we're we're not going to talk to additional speakers until we take questions. So if you have comments about something that's been discussed, please just take notes, and then uh, we'll let you on to ask questions or make comments after we're done speaking with uh, going through these questions with Dr. Haim. Um, so, is there something? Sorry. What authorities do surgeons respect the most? Is it these medical associations? Do you read journals? Is it the department heads? Who do surgeons consult when they try to understand a controversial issue like elective youth mastectomies? How do they feel about you know the evidence-based medicine versus relying on authority or experience? Where does this input for surgeons come from primarily?
So, the unfortunate thing about modern American medicine surgery is that the profession has become siloed, heavily siloed into specific specialties. And the practitioners within those specialties will typically only comment within the realm of their own specialty. So, for example, if you have a surgical oncologist, so a surgeon who does cancer surgery like colon cancer or pancreatic cancer, they will kind of limit their criticism or comment to only that specialty. And the reason is because the perception is that these other specialties have become so detailed, like there's so much nuance that, who am I as a general surgeon to comment on another specialty? So, that plays a role within these trials and these hearings that we see across the country, because the only people commenting on it are the people who are doing these gender interventions, right? But
Yeah.
when you look at the reality, any doctor, really any person, should have the right to comment on this, and especially in this case, because what they're doing is um, it's so antagonistic to the basic principles of medicine that it requires us to speak out against it. But the reason that we don't is because we're so specialized. But to answer your question specifically, there is surgeons are unique because we do have our journals, we read the journals, but there is this mentality where when you operate on the human body, you see the results that and what works for you. there is a huge amount of skepticism towards, the new untested interventions. So, in that sense, surgeons are kind of they're like a cantankerous bunch of individuals who are less likely to go along with something that is crazy, which is proposed. But because we're all siloed, the criticism has, largely come only from the outside of the medical profession.
So, but like if you're a surgeon and you're introduced to something, I mean, new surgeries do come along, new techniques do come along. h- who presents that? Where do you get that information? Where, who's trustworthy, I guess is my question for a
Yeah,
for a surgeon.
so it really comes down to volume. So it's not necessarily like academic centers or non-academic centers. If you have a surgeon who is experienced with a certain technique and they can explain it and justify it, then surgeons will go along with it. And a lot of that is how what you saw with the emergence of like robotic surgery, which I do a lot of. You had probably like 5 years ago, a lot of surgery was being transitioned to robotic. And, it was a lot of community surgeons who were the ones who were taking the lead. So you would have a community surgeon who would, do a couple hundred cases, and then they would show their results at conferences that were organized annually. And then people would see those results and integrate it slowly into their own practice. And over time, what is once novel becomes the standard. So things happen slow, but they usually happen for good reason in the field of surgery.
Okay, got it. Uh and and so people would hear about new things from going to conferences or in journals. Think this is where you would pick up information. This is where you'd keep on top of your own field.
Yep.
Okay. Um, that'll I have another question about that a little bit later. Is there something about the mindset or the experience that makes surgeons vulnerable to seeing sex trait modification surgeries as reasonable despite the high rates of complications and the data showing poor mental health outcomes long term?
I think that surgeons are probably the one group within the medical profession who are least likely to go along with it peacefully. And even though there's not been many surgeons to speak out against it, and the reason is because of the professional consequences if people do speak out. Once there is a crack in the dam, I believe surgeons are going to be the first ones to really, or at least I hope so, to speak out on a large scale. And I think we saw an example of that with the American College of Plastic Surgeons because they're really, and that was maybe about 2 3 weeks ago. They were the
Yeah.
first professional medical organization to not affirmatively support, quote unquote gender affirming care, right? It's a euphemism, but and the reason I say that we're most likely to speak out against is because we are the ones who deal with complications when things go wrong. So when these people describe what they call bottom surgery, when I first heard that and the details of it, it was horrifying. I mean, absolutely horrifying because you realize what they're doing is amputating healthy genitalia and creating a very, very large chronic wound, and that chronic wound is in some of the most delicate real estate in the human body, which is in the pelvis. And that's like a very difficult place to operate. I operate there. And it's very delicate because, on the front of that, right, where they have this chronic wound, you have the bladder, you have the vagina, you have the urethra. Behind it, you have the rectum. So when you have this chronic wound healing, it's like this bed of activity, of metabolic healing activity. So what tends to happen is that fistulas will form, and a fistula is just an opening that connects one area to another. So that's why these people have such a high rate of fistulas because the wound is so large. And I deal with fistulas in other kind of scenarios like diverticulitis, which is inflammation of the last portion of the colon. When there's so much inflammation and the colon is healing, it forms a connection to the bladder. So what happens is people will urinate stool like in air. So like stool will come out of your penis when you're voiding, and that's horrifying. And it causes the worst infections possible. And to operate on that, which I've done before, is an absolute nightmare. And that's only one. But to think about the urethra in these procedures, where there's so much scarring, there's so much healing. When these urethras scar down, these people can't empty their bladders. What happens is all that volume builds up in their bladder, goes up into their kidneys, and cause permanent kidney damage. But then also, you can't necessarily empty your bladder. So there's this constant feeling of like the sensation like you need to void. And even when they do void, because of the scarring, it's not going to come out in one constant stream. Oftentimes, it's deflected from one side or the other. So if they go to a coffee shop and they're trying to void into a urinal, they're just going to do it all over themselves. So that's why you hear these stories that these people just constantly smell like urine, and that's horrifying. And we see situations like that, but because of like naturally occurring disease, and to think that you take people who are perfectly healthy and you do this to them electively is absolutely horrifying. I mean, it's like the most horrifying thing I could possibly imagine because you see the amount of suffering these people go through, but not only them, their entire family, their lives are destroyed forever. And these are things you can never take back because once the anatomy is changed, you can't ever put it back because the like it's a physical thing you see and feel, right? Like after you do surgery like this and there's complications, you can never go back. Never, no matter how many skin grafts, whatever, alloderm, the synthetic tissue grafts from pigs, none of that will ever make a difference to get you back to what you once were.
Yeah, I have to say, I I avoid looking at those photos. A lot of people see them, and it makes me a little I'm not a person who can handle a lot of that information, but I think about surgeons doing this. So, my questions are getting a little mixed up, but the ASPS, so the American Society of Plastic Surgeons, came out with what I thought was a little bit of a mild statement, right? That basically what they said was that they weren't endorsing any organization's practice recommendations for the treatment of adolescents with gender dysphoria, and that there's considerable uncertainty as to the long-term efficacy for use of chest and genital surgical interventions. So that's what they stated, and they said that they noted that the existing evidence base is viewed as low quality or low certainty. So this information is out there. Clearly, surgeons are seeing this in their patients. They have to know that this is you know there's a certain percentage who are going to suffer from these complications. So so what do you think? I mean, but this has been going on, right? For how many years have they been doing these surgeries? So why do you think that the ASPS was willing to make this statement at this point? What what was the tipping point
I,
there?
I think that in the even though it was a equivocal statement, we have to put it in the proper light given the power of the transgender lobby. For them to make their statement and not endorse the recommendations from WPATH, that is that is a huge, huge deal because these surgeons are just as liable to the pressure as anyone else. And especially for a surgeon, I mean, you spend so much time, you spend so much effort to build your practice, and to have these people come after you is a devastating thing. So for these people to not affirmatively endorse it, even equivocally, is massive. That is the first indication that the dam is beginning to break. But and also to you said something about like a certain proportion of these people suffering from the complications. You know, I would say that it's really all of them because the whole process itself is not the restoration of natural health, it's the creation of disease. And that bears out by their own complication rates. So, for example, in some of the videos that were leaked from a WPATH conference, I think it was published by the Daily Caller by someone named Meg Brock. They had acknowledged that their complication rate is up to 70, 80% in terms of urinary complications. You see that rate of complications with only the most invasive interventions on the sickest patients, right? So it's like if you do LVADs, which is a left ventricular assist device, which is a device that you implant into someone's heart when they have end stage heart failure. So, implanting something into someone's heart is like a very big deal because there's issues with infection, with coagulation, with clotting and bleeding. They have complication rates around 70, 80%. But because the the risk of death is 100% in end stage heart failure, the risk is worth it because they're going to die anyway, right? So they put in this device which bridges them until a heart transplant. And in the early days, you had like 90, 95% who would die. And all of this was um, uh, kind of pioneered at Baylor College of Medicine, where I did my training. And so I would work with the people who had pioneered it, and they would tell stories about it. But because the they were so sick, they were going to die. The risks were worth it. And then you compare it to this situation where you have healthy people, right? But they believe something. It's a psychological issue. And in response to that, you have surgeons taking them to an operating room and not restoring anything natural, but creating disease in the most horrific way possible that you can never come back from. So, yeah, I mean, it's it's horrendous.
Yeah. What do you think the likelihood? So we have a crack in the dam. Presumably a crack in the dam. So two questions. The first is, what does that statement mean? How what does it mean for the surgeons who are doing these surgeries currently to have this organization, which I assume has considerable weight or um, significance for in the medical field. What does it mean for those surgeons who are doing these surgeries to have, in minors, because this was specifically in minors, it what does it mean for them to have this statement made by this society?
Well, I imagine they're probably getting pretty nervous. And what it means for them is that a reckoning is coming because the whole foundation of quote unquote gender affirming care, as we know from the beginning, and as it has been supported by documents released from their internal communications, from the Alabama suit, from different organizations getting FOIA requests and requesting their documentation, and then also from whistleblowers like the WPATH files, is that their standards of care were never based off evidence, as they claimed publicly. Behind closed doors, they knew it was not based on evidence. They knew that it was politics. They knew that it was an ideology. So they said one thing privately, another thing publicly. And they did so with the greatest amount of confidence. They did so with so much confidence that insurance companies and a bunch of other medical associations believed it. Whether or not they really believed it, who knows? But they had integrated it into their like payment models, right? Insurance companies would cover it. So now that you have the first break in the dam, there is going to be more liability for lawsuits. People are going to start questioning, right? And they're going to have the answers to these questions. What are we really paying for? Is this really evidence based? And now there's plenty of information out there to show that no, this was never evidence based. And and if this happened in any other field of medicine, if I had, for example, if I told patients, I'll treat your depression by taking out your appendix, and I, publish a bunch of phony articles about how appendectomies treats depression, and information comes out about that was fraud, right? I would go to jail because that's criminal negligence, criminal assault. So that's I think that is what is on the horizon. So yeah, these people are probably pretty nervous, I imagine,
Yeah. Uh,
as they should be.
yeah, I can't imagine, how this plays into kind of the current crop of detransitioner uh, lawsuits that are brewing out there. Um,
And
and
unfortunately, most of them will pass beyond the statute of limitations.
yeah,
You will not get any justice in their case because I believe it's 3 years. From the time of the action. So the ones now are paving the way for the future, but unfortunately, the ones now they will probably never get justice. I mean, they will because the entire foundation is built on a lie in the most clear and cut way imaginable. So they'll get justice in the sense that their sacrifice is going to be vindicated in the end. But in terms of any official legal justice, I think the chances are low. But it's only because they're fighting that they're paving the way for everyone else. That the methods and the strategies are being developed by the attorneys who are representing them, and it's and it just it shows how courageous these people are, these detransitioners, because they could have easily just you know went on living their life, but they decided to fight against something that happened to them, where they were abused, where they were victimized, and to fight against that publicly, to take all that flack from the other side, has got to be one of the most difficult things you could ever do.
yeah, I think it's pretty brutal, and the I don't want to get sidetracked on the cases, but I think this is why the attorneys are choosing these different approaches. So it's not medical malpractice, which has that 3 year in most places they have that 3 year statute of limitations, but these other approaches are a way to get around that rigid timeline. So we'll see. And I want to say we will have. I think it was in March, we had March or April, we had a few lawyers come on and we did kind of a roundup discussion of what the cases were. We're going to have another one, a revisitation of what's currently happening in cases in a couple of, uh, probably in a couple months. So we'll revisit that soon. Um, so um, I- I'm jumping around a little bit, but so you think that ASPS made this statement because the writing was on the wall, that they didn't want to be kind of the last man standing, claiming that this was an evidence-based approach.
Yeah, because the surgeons, plastic surgeons, they know for sure because they operate on people. I mean, there's no way they can deny it because these horrific consequences are a lot of times what they deal with. Because so plastic surgeons not only do cosmetic surgery, right, like rhinoplasties or
Yeah,
but they do like really really complex reconstructive surgery. So massive tissue flaps, bone reconstructions. They do facial reconstructions using bones from your leg to reconstruct your jaw. So these are very serious practitioners. I mean, they are very familiar with the horror that is happening to these people because all they have to do is read the description of the surgery and what, like like a urethroplasty, the urethral stretching. And to any surgeon who's ever, operated in the vicinity of a urethra, that's just something that sends chills down your spine because, it's like this couple millimeter tube that if you mess up, you are in a whole world of pain.
yeah. Wow. So, yeah, this whole surgery aspect of this, I think, um, yeah, has is kind of nightmarish, certainly for people um, who hear the detransitioner stories of what they're going through um, after these
And it's
surgeries.
not to say that the surgery is like to because a lot of times people look at the medications like hormones and puberty blockers like they're less severe. They're kind of like a middle ground. But I would say the exact opposite because the these medications are so potent that they permanently change your anatomy, like your physical anatomy and your physiology from the inside out. So, like, there's no surgery in the world that can deprive your bones of the kind of molecules necessary to become a fully grown adult, right? Like, there's no surgery in the world that can deprive your brain of the hormones necessary to develop like a mature brain. There's no surgery that can, take a child and then completely arrest their sexual development and like produce an 18 or 19-year-old male with a sexual anatomy of an 11-year-old. But that's what's happening, right? So with these puberty blockers, it's like a million microsurgeries, but on the cellular level. So it's from the inside out. And it's because these these changes are so gradual because they're so subtle and they happen over a long period of time that people see it as some type of middle ground. But I would say it's almost just as bad, or if not worse, because you can't see the changes. These are things you cannot quantify because it changes everything in your body. I mean, your hormonal system controls everything. I mean, your emotions, you're right, like the fight or flight response, like the ability to love, it's like the hormones you felt when you were like 13 or 14 when you had your first girlfriend. Like that's what they're stealing from these kids. And those are things you can't put a measurement on. But and that's what they're taking away. So it's the surgeries are horrifying, but the blockers and the hormones are just as bad.
Yeah, yeah. Well, it'll be interesting to see if any additional medical associations follow suit. When and I think part of that gradual thing that you're mentioning is what keeps it going, right? If a clinician gives a teenager what they're asking for, right? They've been begging, they've made a big deal about getting hormones or getting blockers, and they see these happy children, these happy teenagers who are, otherwise not functioning well, and they're giving adolescents what they're asking for, and they see this incredible, relief and response, and I feel like that's what these clinicians are responding to. They're responding to kind of this visceral feeling of, you've made somebody happy. You've made somebody appear to function better.
Mhm.
But
It's like the
but
illusion of short-term efficacy without the consideration of long-term harm. And we saw that with, for example, like the opioid crisis, where you would have these phony, fraudulent studies come from the pharmaceutical companies themselves, with assistance from university programs or the government, and they would say, there's no risk of addiction using like OxyContin or oxycodone. So, these doctors, they would prescribe it because they would see the immediate benefit in their patients, right? Their patients had this debilitating pain when they came into their clinic, and then they give them these pills, and then they come back a couple weeks later and they're like, "Oh man, I'm happy. This is great. Where can I get more of this?" But of course, these are like naturally, like these are inherently logical consequences to something like this. It didn't take a genius to figure out giving people strong opioids is going to turn them into addicts. It's going to destroy their life. So we've been down this road before, right? We get fooled by the illusion of short-term efficacy without fulfilling the responsibility to consider the long-term harm. So it's the same thing happening now. But at least with the addicts, they were still themselves. They still had their own name, their own bodies, that they can go to rehab and become the same person. They can redeem themselves. And the detransitioners still can too. But the issue is that their anatomy and physiology has been permanently changed. And there's no coming back from that.
yeah, so I'm going to jump around again because this idea of opioids, I I mean, when you say it doesn't take a genius, you're talking about a drug that is absolutely known to be addictive. I mean, the idea that it wouldn't be addictive seems ludicrous. But but you know, clinicians prescribe, I know clinicians who prescribed opioids, and um they're not losing sleep over this, and maybe their patients were ultimately okay, or maybe they only saw them once for 15 minutes or 20 minutes and that was it, and they don't have a connection to them, or maybe it's a function of the profession that you don't have a personal relationship with your patient, or maybe there's a sense that the patient is ultimately responsible for their life and their decisions. Like, this is what informed consent is largely about, that people have to, here's what we know and you have to make your decision, and we'll give this information. Although I've seen the informed consent forms for hormones, certainly, and for surgeries, and they're pretty bad. But do you think that gender clinicians are losing sleep over the concern that they've harmed kids, or are clinicians so well defended that this does not enter? Is it like the opioid crisis, where it's like, well, this is what they told us to do. We were going to get poor, it was the where you pay, when patients could start grading and rating their clinicians. That was a big deal. So you didn't want to not take care of somebody's pain because you'd get a bad rating, and then your standing would go down, and you'd get a reprimand from your department head and all this stuff. So, is it such a function of being a clinician that they're not losing sleep over kids who might have been, guided down the wrong path, but this is part of life and the journey and all that.
Yeah, I would say the rationalizations are in place. They're ironclad. It is so strong that it allows them to take a vulnerable young child and, in many cases, sterilize them. So I think that at some point, just like the opioid crisis, like every lie will eventually crumble into its component parts. The history has taught us that anything that is built on a lie will be destroyed eventually because it cannot withstand the test of time. But many of them will not lose sleep because their rationalizations are so strong that they'll find a way to justify it to themselves, unless they are held accountable publicly. Then yeah, I doubt many of them will lose sleep. But that's why the onus is on us. We have to be the ones who hold them accountable, because this is bad, right? It's the only way to prevent these kind of things from happening is by holding people accountable to make the shame so great that people in the future never consider doing something like this again.
Yeah, I think about these surgeons. So, there are surgeons who have not only been willing to perform these, dangerous and unproven medical procedures, but they have glorified and they've celebrated the act of severing healthy body parts, right? Removing healthy body parts. And again, these are in you can't overemphasize enough the point that these are perfectly healthy bodies that they're operating on. There is nothing physically wrong with the body. They have no disease state that they're curing with this. But there are surgeons who are happy to do this. They're driven to do it and they're celebrating it. You think about, like, I don't know. I've seen it pronounced Shiv and I've seen it pronounced Sive Gallagher, right? Who's in,
Mhm.
I don't know if she's still in Florida, or Orrin Gaynor, who's that surgeon who operated on Griffin Sivert, who passed away, or Crane, that who has like three clinics. I think he's one in Texas, one in San Francisco, and someplace else. He's the guy who does these gender nullification surgeries. So, you know, how is that? How is it that there are no safeguards or medical ethics in place that would serve as a control against people like this?
Because the consequences of speaking out are so severe. I mean, there's no safeguards because the safeguards have been destroyed. I mean, that's the simplest answer. The people who are like a good way to look at the medical profession is like a herd of animals, right? Like doctors are by nature herd animals. And I don't mean that in like a pejorative way, but it's like doctors tend to follow the recommendations of leaders in the field because the belief is that, all right, these people kind of have a generally pretty good understanding of what's going on. Some specialties more so than others. I would say surgery less so, other specialties more so. And if you have responsible leaders at the head of that pack, then the pack is going to move in a pretty good direction. And, we saw that throughout the 20th century, where medicine had made like some really good strides. Of course, we had made some monumental mistakes, but for the most part, things we were able to treat human disease. And I would also add one disclaimer, like we got really good at salvage procedures, like when someone gets really sick and like acute interventions, like we got really good at that in terms of promoting long-term health. It's like we're the worst people imaginable to do that. It's you couldn't imagine a group of people less capable of promoting long-term health than modern doctors. But so when you have the leaders of the medical community, right, the establishment, who are also part of this ideology where they believe that truth is not something to be observed in reality. It's not objective, but rather it's subjective. It's something that if they say something is true, then it's true. And if you question us, we're going to call you, all these bad names and destroy your career. So yeah, I mean, there's no safeguards because the safeguards that have were put in place are destroyed. And for the most part, doctors are too timid. They love their money more than they want to preserve a future for their children.
Yeah, this point, of sacrifice. Again, I'm this is completely destroying my notes, but the idea that so like I said, I know doctors. I have doctors in my family who don't speak out, and I think there's the fear and the risk, right? The risk. I mean, I I don't think that you can expect people to really sacrifice, if they have a family to support or all of the time, and blood, sweat, and tears that has gone into to getting their position and their education. But is there a way that clinicians can realistically push back without going the route that you did, which unfortunately people won't do? But that situation was very specific. But just the idea of speaking out and saying, look, people in my field are doing something that I think is dangerous, that I think is harming people, vulnerable people. Is there a realistic way to do that when you feel like you're isolated or and you don't want to jeopardize your livelihood?
Yeah, no, I think that I would say it's not justified for them. No, that they to call themselves a doctor, it is their responsibility. So if that means sacrificing their livelihood, then that is the right thing to do. Right? Of course, there's different ways to do it. And people are in different situations. But, it comes from a inappropriate calculus, right? Where doctors believe, well, I can't speak up because if I do, I might lose my job or I might not be able to pay for this or, I've worked so hard for this. But what they're going to realize is that when they don't speak up, they're going to have to live with that shame for the rest of their lives. That their children are going to have to look at their parents and think, well, my father or mother was in this situation and they didn't say anything. They had the opportunity to do something and they didn't. So the shame, the consequences of that, in my opinion, are far worse than whatever material sacrifice you have to make in the short term. And even so, I should be a testament to it that when you make a sacrifice like this, it's not like all is lost. I mean, I still have my medical license. My practice is busier than ever. More people are coming to my clinic because they read what's online. They're like, "Oh man, here's a doctor who actually stands up for what's true and is willing to sacrifice for it." In many ways, it's like the opposite. It's like if you speak out, you'll become 100 times more successful because everyone knows this is complete garbage, right? And they're looking for a doctor who actually cares about them and is willing to fight for their profession. So I think it's complete bullshit when doctors say like, "Oh no, I want to, I don't want to risk this or that." It's like when we take care of these sick people and we see what kind of suffering they have to go through, and we're unwilling to do the right thing and protect them and to sacrifice something meaningful, like, can we even call ourselves doctors? Like, no, we fucking can't. So you have to sacrifice for it. And you can't call yourself a doctor if you don't.
And, but I guess how much power does this, like, can how do you as an individual, I'm trying to put myself, I'm trying to be fair and put myself in the place of a clinician who doesn't know if any other doctors in their practice or in their clinic feel the same way that they do, because everybody is afraid to talk about it. It's not their field, but their hospital system has, this kind of specialty. So, as an individual doctor, you know, how do you even, like, put word, how do you communicate this? Who do you communicate with? Like, what would be a realistic scenario where you could foment change in your organization?
Yeah, and it's a really good question. And the good thing is that these doctors can use well, in some ways, they could use my case as like a positive thing, but also a negative thing, right? It's like because if you speak out, you realize that there's so many people who actually agree with you, and that once you do
Right.
start speaking out, more and more people are going to come to your defense, and that's what we're seeing because people in my old program, right, would never say something publicly, but now they're reaching out to me privately, and that's the first step to them saying something publicly within their little sphere of influence. And if they do start speaking out, like success will come to them because success comes to people who sacrifice. And yeah, like they might lose like maybe a job opportunity or something, but like the success in the long run is so much greater. And also it's like the success of your family and your children being able to look at you and knowing you're not like a spineless coward. Like that means a lot. Like that's actually a pretty big thing. But when in terms of like the sphere of influence, there's a million opportunities where doctors can speak out, within their hospital systems at meetings if they work at one of these hospitals, where they can go to like a board meeting or like medical uh, like a medical staff meeting. Those are really common. We have those like twice a year. They can go to their professional societies, like if they're an endocrinologist, they can speak out their endocrinology conference. Surgeons can do so at the surgery conferences, and just by nature, that so many people are scared to speak up, they can have a huge influence. They can be the first ones to initiate a tidal wave within their own spheres of influence, which is an amazing thing to do.
Yeah, I don't know that we've seen. I mean, we obviously we know clinicians who have spoken up, but it does feel like a small but growing contingent, and it would be really, um, it overdue to see clinicians identify others who are willing to speak up. I mean, I always thought, sure, if you're one doctor in Kaiser, say, you, you're never, you will be kind of destroyed, professionally destroyed there. But if you're 100 doctors in Kaiser, you know, and you make a public outcry, y- that would make a
Well,
difference.
it's I would say not necessarily because when you have one person who speaks out, uh, I mean, that's kind of what happened in my case. It was just
Right.
me,
Yeah.
and I was a nobody. I mean, I still am, right? I'm just a random guy, and the power of one person cannot be understated. And it kind of goes back to um, quote, I think Orwell or someone. It's like when you live in like an empire of lies, telling the truth is like a revolutionary act, right? And
Hmm.
you have one person who tells the truth, and it turns into like a cascade effect where you have so many other people who are in the audience or in that sphere of influence where they see it, right? They see someone who tells the truth, who risks everything, and they see a part of themselves where it's like either they can decide to live with this shame and stay silent, or they can decide to do something differently and speak out. Kind of call to that inner sense of truth within themselves, and it'll start happening. Like that's what will happen. And even though they might have to sacrifice a few things in the short term, the long term benefit of maintaining your dignity is the most important thing that we cannot underestimate. Because after all this happened, right? For the first time in my life, I can wake up in the morning and then look at myself like I wasn't lying to myself every single day. And the sensation of that, to for the first time in my life, just live according to what I know is true, and what is true is the most amazing thing ever. So you become immune to the consequences that they tried to inflict on you.
Yeah, 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 yeah. It's beyond meaningful in the short lives that we have.
Yeah, like we're
To
all like I just by the nature of my profession, we're all gonna die, and I see it all the time. Because we deal with a lot of acute cases, like we're all gonna die, and it's not gonna be pretty, and it's gonna be pain and a whole lot of suffering. And you see these people during their last moments, and there's always people who you have a sense of regret, where there's things they wish they would have done, and we're all going to be in that situation. We only have one life, so why spend the time we have bending the knee to something we know is evil when we can get into a car tomorrow and we might not be here the day after. So it's the we're given this opportunity to do something, and we have that chance. So it's like, why not live a life that's worth living?
Yeah, it does seem in the whole scheme of things, you'd think about your lifetime, to exactly to bend the knee for this. I would love to leave to end this on that very lofty note, but I still have these questions that I want to ask that are not lofty at all. So,
Yeah,
I'm gonna
I mean, however long you guys, I don't have anything to do, so.
Okay, so I'm gonna there's a couple things that came up, people who submitted questions, people on our team, and they just want to know some things, and then there are some other questions that I think are important to ask. You mentioned your comment you made a comment in your interview in on Gender a Wider Lens podcast early on, and you talked about surgeons having an instinct to circle the wagons, so a reflex to lash out at criticism of the profession or any attempts to regulate it, and to automatically defend what your colleagues are doing. So, can you speak to that reflex? And also, have you seen instances where concern for patient safety or the reputation of the department or the profession resulted in surgeons speaking out, against that kind of circling the wagons reflex?
I would say that the circling the wagons is more of a reflex that happens kind of on the macro scale, where it's, uh, if like a procedure is being questioned and like kind of bogus evidence is being used, and like actual evidence where it's like, you can go through it and it's legitimate, the statistics are correctly interpreted. But no, I would say on like a professional level, like on the individual level, um, I would say that it's kind of less so because when things go wrong in the hospital, like if the wrong person, if something was left in the abdomen, or a specimen didn't get sent to the right department to be evaluated by a pathologist, um, at least in throughout my training and then my year as a attending, um, we've always been very like straightforward with patients. So like, on the professional level, like, individually, we tend to it's which I think should be reassuring because,
Yeah.
we're typically very honest if something goes wrong, where, like, the immediate reaction is to not circle the wagons, but to be very honest with, like, everyone involved. And that is a reflex that, I have seen in the vast majority of surgeons I've worked with.
But then, you take someone like these ghouls who, you see tremendous cases of infection, right? I mean, I've seen, patients who are can't get they don't see the patients again, and they're complaining about infection, and the clinician, especially like Gallagher, says, "You're fine. This looks great." Somebody sends them a picture. I don't know if anybody else saw this. It was horrific, horrific infection. So so you have somebody like that who's clearly not operating within the realm of a normal surgeon, right? So that mentality isn't clearly not present
Yeah,
with.
and it's a very subtle thing because the way to identify those types of surgeons, and if any of you have seen the documentary on Netflix, like Doctor Death, about the guy who was doing trachea implants in Sweden, there was a certain pattern that he exhibited that also these doctors tend to exhibit, which is they have very short, brief follow up with a tendency to discharge the patients from their clinic. And the reason that's important is because, like any good surgeon, uh, will always follow up with their patients, like no matter how long. If it's anything related to their surgery, like there's no time limit. I'll see patients if it's I haven't been in my career that long, but if it's 5 years after, right, and they think it might be something to do with the surgery I did, always, there's no question. But you always take ownership over anything that even might be perceived as wrong. It's like the natural instinct for a good surgeon is like, no, this is my fault. It's my fault until proven otherwise. Like I made a mistake. Like that's the baseline reaction for a good surgeon. And in these cases, you see something completely different. And that's how you can tell the good from the bad. And that's where the instincts are going totally haywire, where that's very dangerous, to have these people with the authority to bring someone to an operating room where they're going to lay them on a table, naked, unconscious, and paralyzed. That's something that is extremely dangerous.
Eh, I have one specific question about Gallagher, and then I have a more general question about this realm. That I've heard her say, or heard people say that she has no malpractice insurance, and that somehow this protective. Is This is a question somebody on our team asked. So people have heard this. Is that a thing? Like, do you know anything about that? Have you heard that about that surgeon?
I could imagine what they may do is part of the intake forms, part of the paperwork to in order to be seen at that clinic is the signing of like ironclad waivers that says that they will not sue uh, the physician. And maybe that's the reason why she doesn't have malpractice insurance. But because even if you do sign that waiver, you can still sue someone. It's like if you have like a non-compete clause with uh, a hospital or something, and then you leave that hospital. Well, like yeah, you might have a non-compete clause. You could break that, but you just have to go to court, right? And it's expensive. It's a pain in the butt. So
Right.
maybe that's the logic behind it. But I would
I don't know.
that probably wouldn't be the best one to comment just because it's just that would just be my kind of uneducated guess about it.
So, you know, so you have these clinicians and they're doing this stuff. And or you take like Crane who's doing these gender nullification surgeries. Like, this isn't evidence-based stuff, right? Because they're inventing these kind of structures and this kind of cosmetic look. Um, is there a realm, is this medicine, number one? And if it isn't, is there a realm where this exists, where gender affirming surgeries exist? Maybe it's outside of medicine, or it's within medicine in its own category. Like, is because there's the ongoing discussion of, well, if you're an adult, because at 18 you become magically wise. If you're an adult, you should be able to do these things. So where does this realm of surgeons exist? Is it within medicine anywhere?
Mhm. And, it's such an important question because, it's, uh, there is a very specific answer to this, in my opinion. And a lot of it can be traced back to, I think the best, defense of this, best explanation comes from Aristotle's Nicomachean Ethics, where he talks about medicine, he talks about health and the role of the doctor. So, the role of the doctor is to strengthen and preserve naturally occurring physiology. And like that statement by itself may seem kind of complicated, but it's really not if you think about it. Whether you believe in God or you believe in evolution, we're all created in a certain way to allow for human flourishing. So, for example, we have two legs, we have two arms, we have eyes that see, we have lungs that breathe, and a heart that pumps. And we have an endocrine system that starts working at a certain time during your development to initiate your progression into adulthood. And all of that is functioning by an internal logic. So when all that is functioning properly, like we feel good. Like you can go to work, you can go, to the pool on the weekends, you can have children. Like that is what you would call health when things are functioning normally. So the doctor's role is when things are not functioning normally, right? Like an aberration from that natural state of health is what we call disease. So if everything is going well, right, and then all of a sudden I have some belly pain, right, and it's not just a couple hours, but it's persistent. It's going on for a whole 24 hours. There is something that is aberrant about naturally occurring physiology. So someone comes into the hospital and they get evaluated for this thing causing abdominal pain, for like a disease. So the doctor's role specifically is to identify what the disease is and to treat it in a way, with the least invasive techniques and in a way that at least we will not cause harm, right? Understanding that there may always be the risk of harm with treatment. So the doctor's role is to preserve and strengthen naturally occurring physiology. What is happening with these gender interventions, whether it's hormones, blockers, or surgery, is the exact opposite of that. It is the destruction of naturally occurring physiology because they misidentify a psychological problem for a physiological one. They take an individual who has a healthy hormonal system, give them puberty blockers or hormones, and then throw them into a aberrant state of disease, right? If it's puberty blockers, they will put them into a state of complete absence of gonadotropic hormones, right? They'll go into a state of menopause, right? They get depressed, they start having hot flashes, and all this at the time that they're 11 years old. If they have hormones, right? You have a body that was created to live naturally in a certain hormonal balance. When you give them mega doses of testosterone, right? It's the risk of stroke goes up, of heart attacks, right? Your bones form differently. You start growing hair where you shouldn't. And these all lead to these downstream effects, which take you away from this naturally occurring state. And then the surgeries anatomically, will permanently alter naturally occurring organs and oftentimes destroying critical functions such as lactation, urination, sexual intercourse. So medicine is kind of what I alluded to before. It's like the preservation and strengthening of health. So what this is not just bad medicine, because bad medicine is like a poor diagnosis or like maybe a failure in execution. You kind of operated later than you should have. That's like bad medicine. It's oriented in the right direction, but it failed in execution. It's not necessarily like alternative medicine either, which uses like different means of treatment. What this is the exact opposite of medicine. It's anti-medicine because it's being oriented towards the exact opposite of what a doctor should be doing. So, to answer your question in a very specific way, I would say no, there's no rule for this in a doctor's profession because doctors do not exist to create disease. We exist to prevent it and to eliminate it.
Okay, but then you look at something like, some of the cosmetic surgeries, right? I mean, if you have a functioning nose and you just don't like that it has a bump instead of a curve, or you want bigger breasts, you want to be more sexualized, or whatever reason, somebody wants to do that. Or, you want a tummy tuck or you want liposuction. I mean, those are not, I mean, in that case, it's not a functional norm,
Mhm,
right? Their
mhm.
bodies are functioning fine. So,
Yeah,
how does
it's such a I'm so glad you brought that up because it's such a good point, right? So I would say it's a difference between two things: modification and transformation. So, a cosmetic surgery can be done on a physical attribute to change its appearance to have it more aesthetically pleasing. But even if someone wants to make it look completely different, like completely, the person who wants to turn himself into a tiger, right? They want eyes that look a certain way, or like teeth, right? It's like the doctor is not telling them that, yeah, you will become a tiger, right? They're saying you're modifying your body in a certain way. But in the process of that, like whether it's breast augmentation or a nose, there is no function that is being eliminated or reduced. And if it is, that's a problem. But what is different about the gender interventions is that they are occurring under a presumption that the patient will become something that they will never become. These doctors are telling them that, you will go from a man into a woman, right? And that this will transform you. And those are false. That is completely false. So it's happening under false pretenses in the belief of transformation, and which is completely different than modification. But in the process, right? And the more important thing is not necessarily the pretense. The more important thing is that function is being destroyed with the hormones, the blockers, and the surgery, and all of those, function is being destroyed, which would never be tolerated in a cosmetic procedure if you were to permanently alter physiological function in an otherwise normal, healthy individual. But in these cases, the expected known side effects are all function, like limiting of function. So they may appear similar, but they're two completely different categories, and it all has to come down to function.
Okay, totally. That totally makes sense. I'm gonna continue to play devil's advocate a little bit, but okay, so say yes, but I'm an adult and I don't care about the function. That I as an adult have, bodily autonomy and I want I want to look, I want people to get other people to mistake me for the opposite sex. That's what I want. Is there a realm where that, even though it's destroying function and you're causing problems, is there a medical world where that exists? I mean, I see, I- I'm sure you've seen this subtle shift from patient to client under certain circumstances, and this idea that maybe evidence base maybe the evidence base isn't what's important here. Maybe serving, you are providing a service, what that evidence is not doesn't even come into play. These are kind of extreme, maybe because extreme cosmetic um, or physiological changes that we're going to provide. We're going to provide these services, and it's not curative, but we're providing this service, and we have training. We're surgeons, so we have training on how to do it surgically to make your genitals look, I don't know, different, and or take them off or whatever, and make you look like a Barbie doll, or change your face and all this stuff. And is there, what about that realm? Does that exist somewhere? Is
Yeah,
that
I think it's another brilliant question, because something very, very important to clarify. So the role of the doctor, right, which has kind of stood the test of time, right? Like there's something that is unique about the role of the physician that's been recognized throughout all of human society. and the role is to heal. Like you can always tell a good doctor from a bad doctor because bad doctors will make people worse, good doctors will heal people. So I would say there is no role because if even if an individual wants it, the doctor has to make the decision like, is this preserving their natural health? If it is not, then no, then you can't do it, right? Even if they want it, right? Like, and you would call that person something different if they did, like maybe a witch doctor or a shaman or a butcher. And other societies probably have had that at some point in time, but you cannot call that person a healer. And there was actually a situation I had somewhat recently where I was doing a hernia surgery on some guy, and uh, he asked me, he was an older gentleman, and he asked me if I could remove his testicles, just because he didn't want to have them anymore. And this had nothing to do with the gender thing. It's just he told me they were kind of a pain in the butt, and he just didn't want them. And I was kind of taken aback. I was like, no, of course not. No, like I can't do that because you're exposing this person to this huge amount of harm from the surgery itself. Like the surgery itself can cause a million issues. So when the risks of surgery outweigh the benefits, when there's no reason to do it, when you're not restoring any type of natural physiology, no, there's no role for a doctor to do it.
Yeah, I kept thinking, okay, well, you fine. You don't get to like maybe there's schools that, yeah, I don't know. I couldn't come up with scenario that would make that feasible, but maybe somebody else has some
Yeah, well,
idea.
it's like I mean, you could like you can live in a society where you could do that, but I
Yeah,
just wouldn't call those people doctors.
right. You wouldn't. You don't get to hang out your shingle and put your medical license up and say, I'm a doctor, I'm a surgeon, you
Exactly.
know,
Yeah,
and I'm going to do these things that are not medicine. No, you
yeah,
you could do something else. Maybe you get some kind of weird license that says you make physical changes to people, but it's not a doc,
yeah,
not
and
an
and
M.
that's why we don't prescribe people opioids who are addicted, right? Because we know like even though they really want it and say, what, I just want to live the rest of my life addicted to opioids. We don't give into
Right,
that. We don't
right,
just allow that because we know it's not good because like it's not worthy of the dignity of the individual that they should live their life addicted to a drug. That there is a way that we all know which is the best way to live, which is apart from doctors. Like you should not rely on a doctor to live your life. And it's like that is like the way in which a doctor is oriented. And if someone is oriented in a different direction, then they should just not call themselves a doctor, right? It's like a witch doctor, a shaman, or a butcher, right? And
yeah,
if a side wants to do that, so be it. But at least in my sphere of influence, I would be antagonistic to that.
right. And I think at the same time, this is where you can't call it life-saving care. You cannot introduce disease and illness and call it life-saving
Yeah,
care. That
yeah,
that doesn't. Okay, so we talked about the ASPS statement, and at the same time as that was happening, around the same time, we had these recent revelations that we have Levine at HHS, and uh, Admiral Admiral Levine was working hard behind the scenes to get WPATH to remove the age limits on interventions because it was bad politically for the movement. Um, and yet we have the AAP highlighting. Levine is the keynote speaker at their conference this year in September. So is that is either the biggest screw you to everybody who is pushing back against this, or this information is just not penetrating. That for whatever reason, and there was something you said too, that about it was about Texas Children's Hospital and how they were stopping, but it wasn't. It was because it was because of other things like trying to think of what the statement was that you said. It was not about it was about concerns about liability, that's why they were ending it. It wasn't the concern that the knowledge base was changing or because maybe children were getting harmed. It was it was about liability, which I guess tangentially is related, but not quite. So I wonder, is is the information just are these organizations and are these clinicians so impenetrable that the information that we're all very well versed with, is not getting to these people? And so that would make a decision like bringing in Admiral Levine as your keynote speaker reasonable.
I think it's probably two different things. I think that if they were to give in to show any sign of weakness, then that would initiate a quicker decline in this house of cards, right? Because they've committed themselves to a lie that is so egregious, that has caused so much harm, that any type of self reflection is necessarily going to result in self immolation. Because if they did begin to hesitate, right, that kind of initiates the process of self reflection, right? Because hesitation comes from some degree of self reflection. If they were to do that, they're going to have to come to terms with the fact that the people they claim to be protecting, the people they claim to be like the saviors of, were actually the ones that they were destroying. And everyone else who they had, claimed were destroying these kids were actually the ones who are saving them. So there's one part where it's probably their own necessity to avoid self-reflection that plays a role. But then you can't necessarily underestimate the degree to which their bubbles are impenetrable, because they really do live in a different information ecosystem where stories like that maybe are released in like center of like middle of the road or like right wing organizations, like they will simply not see or hear. No one will talk about them in their circles. And the reason I bring that up is because, yeah, I had, personal experience with this where, this whole thing has been going on for me since January of 2024, right? So it's a good amount of time where like I've told this story on pretty big platforms, like, you know, like pretty big. And um, my wife's friends, are on the, far left, right? They're pretty liberal, and but even my other friends who kind of are like center or center right, they've not even heard about it, the whole story. So like all this has happened, and if people just don't hear it, it just doesn't exist to them. So that it's just not even a consideration. So yeah, I've come to understand that the information ecosystem can truly become an island unto itself if people have a certain disposition and a certain bias towards certain like information settings.
Yeah, that's important, information to have because that means that, our efforts have to extend, into the medical sphere in some way. I think, you have to do some digging to figure out how you penetrate that particular bubble, but that seems like a bubble that's necessary to
Yeah, and
to
and I
put
would I would say for the most part, we've been, relatively, we've been making baby steps, but baby steps nonetheless. I mean, you had a story in the
yeah.
Washington Post, a couple in the New York Times, you have the Free Press, you kind of have people like Bill Maher who are starting to question things. You have people who are kind of emerging from this like zombie-like trance where it's just like toe the party line, and you don't question a single thing. Whatever the elite of the party say, you fall into line. But now there are more people who are being to question it, and I think that's a good thing. That's great that more people are. My uh, I have someone, my related to my family, the farthest left wing California people you could possibly imagine. But this whole thing is shocking them, right? This is breaking them out of this information bubble. They're starting to question things, and so much so that it's actually very, very hopeful that no matter how someone can be politically indoctrinated, right? Like how their entire ecosystem can be, kind of an entire avalanche of propaganda. If there's like one little thread of truth that gets in, people will have a tendency to identify that thread and start pulling on it. And they might not always unravel the entire truth, but they might start pulling on it a little bit. And as long as we keep on feeding that thread into this, kind of ecosystem of garbage, then you hope that people can find some truth and kind of pull themselves out. It's a gradual process, and we just have to be patient and provide people
Yeah.
like a safe place to come. It's like, yeah, like, all right, so you kind of bought into it in the beginning, but then you change your mind. Like, that's cool. Like that's okay. We understand. Like, we have to have a high degree of mercy for the people who are fooled and who demonstrate, that like who are sincerely apologetic. I think there are some people who deserve no mercy, the ones who are at the top of it, the ones who have proliferated it. But for everyone else, we should always, extend a merciful hand.
Yeah, we call that the Golden Bridge.
Yeah, Golden
The
Bridge.
Golden
Yeah, with like an escalator, and breath mints on the way.
Right. Okay, so I have 2 more questions, then we'll get to questions, from the audience. The f Vanessa Savage, who exposed the, alleged Medicaid fraud at Texas Children's, was fired last week. So, maybe that was inevitable, but can you talk about her situation at all? Aren't there isn't that what whistleblower protections are about? How does this happen? And also, if her claims are true, what will be the outcome for those accused of fraud? How high will this go up to at Texas Children's Hospital?
So if the claims are true, then that's a major, major deal. And um, if I were to, because I can't say one way or the other just because I'm not
Yeah,
privy to that information, but I think it's very likely because that's what they advertise from WPATH, right? Like there's tons of documents online. I mean, it's like a pretty quick find, where you can get information like recommendations about how to like get around insurance companies, or laws for reimbursements just by changing your coding. So, like, instead of using gender dysphoria, like, which is connected to a very specific ICD code, then you just change it to like estrogen deficiency in a boy. But since their medical record says female, like the insurance company doesn't know, like they don't know that that's a transgender, like someone who believes this. They just see female estrogen deficiency, estrogen supplementation. To them, it makes sense. But what's actually happening is a crime. Like that's a huge, huge crime. It's not like the worst thing you could possibly do as a doctor, right, is to negligently kill someone. The second worst thing you could do is like to defraud insurance companies. That's a major problem. So yeah, the consequences are severe for the doctors who are doing it, but then also for the hospital if this is true. Like, and that's the thing is because Texas Children's really is an amazing hospital. Like they do the other departments are phenomenal. They do amazing surgery and they really take care of sick kids. But it's hard to believe. Well, I can't necessarily say that now, but uh, I it's such a crazy thing to do to fire her. I but it would be consistent with what they've done in the past. I mean, because at this point, I
okay.
can't necessarily
Yeah.
offer assume goodwill, or the benefit of the doubt when it's just been violated so many times. And that is a relatively small population of the hospital. Most of the people working at Texas Children's are amazing people who do like the best work possible.
Yeah, sad that these organizations are kind of destroying their reputation for this insane, one insane aspect. Okay, my last question, I think, is that GenSpect USA just announced that you'll be serving as Director of Medical Ethics and Policy. So, can you tell us anything about what that position entails and what GenSpect's ethics and policy goals are at this point? I know this is new, so maybe.
Yeah, so, Stella O'Malley, she's amazing, and, she asked me if I would, be willing to, hold this position. I thought it was great. I thought it was very ballsy for her to offer the position to someone who's being indicted with 4 felonies and faces up to 10 years in prison, and to have that person as, the director of ethics. And, our previous lives, like, before the past couple of years, that'd be pretty odd. But, I think it goes to show that, she has some serious courage, right? She's got some cojones on her. So I have a huge amount of respect for that. In terms of what it entails, I think we're in the process of figuring that out now. Of course, over the next couple of months, it's going to be crazy because we have our trial coming up in October. But you know, yeah, I look forward to it because yeah, I've even from the very beginning of knowing about this issue, and it was always GenSpec that was doing good work. So we'll
Great.
see kind of how it plays out in the future.
Okay, I think I've gotten through my most important questions, and I know people are going to have questions. So we're going to move to questions finally. Please stick to the topic at hand. Please be brief and use your time to ask a question. If you have a statement to make, I would really prefer if you would use the chat to make statements. We want to give as many people as possible a chance to ask a question. So that might mean that I need to cut you off. I don't mean any offense by that. And know that I will definitely cut you off if you're not civil. One thing that always happens, I don't think we've ever had a space where this didn't happen, is that in the beginning, hardly anybody queues up to ask a question. And then in the last 10 minutes, all of a sudden we get 15 people who want to ask questions. So better to queue up now, be brave, queue up, have your question ready, and then if you decide not to ask it, or you're not sure about, or it's already been answered, that's fine. Just go on and drop off. But I'd rather that people queue up now. So let's see. Okay, we've got. I see them in order of operations. So I'm going to go by the order that I see them in. Also, this is important. We've encountered problems before trying to shift listeners who want to ask questions from listener to speaker, and especially if you're not on an iPhone. So if you're having trouble getting elevated to speaker, or it seems like we're not hearing you, or you're not able to ask your question, please try logging out and logging back in, or post your questions. We have somebody, our tech person is monitoring the chat, and we'll do our best to get to those questions. And I do have one question from the chat, but I'll go through the first people that are in line here, and then I'll switch to the chat. The first is our friend Aaron Friday. So, Aaron, we're going to bring you on. After Aaron, it's going to be Emmy Pinkhurst. So, Aaron, you should be able to speak. There you
Um,
go.
yeah, hi. Thank you, doctor. We parents who have kids that who were caught or are caught in the cult are really grateful for people like you, and we've been waiting for years for the doctors to come on out and help us. So I appreciate that. Um, my question to you is, if one has an opportunity to speak with an audience of, let's say, pediatricians, what would you advise the conversation be? How do you think a layperson can reach a pediatrician about this issue? And then the follow-up is, once they peak, what do I tell them to do? How do they then take that information and take it back?
Yeah, and you're out of California, right, Aaron?
Yeah, I think Aaron's cutting out a little bit. She is in California.
Yeah,
Yes.
yeah. I know you had led that effort in California. I think that's amazing. You know, but about your question, so a layperson talking to pediatricians, I think there's a few important things. Number one is if it is a large group of pediatricians who are antagonistic, then you can expect a huge amount of resistance, if not like outright mutiny. Like they will go crazy. So like if making sure that it would be like the right group of pediatricians, or if you can recruit a few of those pediatricians of the group to lend you credence, and because doctors are kind of we're like timid horses, you know, like we get spooked very easily, and we run in herds, right? So if you have like one of those pediatricians, like you give your statement, and then one of those pediatricians will then speak out like in favor, then the other pediatricians will then like be granted license to um, express their honest opinion. So what may not be a bad idea is like if you're talking to them, like maybe have someone you've spoken to before in the crowd who can like lay the groundwork for other people to speak. So it's not just like a chorus of opposition to the crowd, but then also like making sure you have the literature like on hand, and like you know how to express it in a really confident way. Because the one thing that doctors really get jazzed up about is when someone can like cite the literature but be able to express it in a way that's authoritative, and that's something that will give you a huge amount of credence. Because when you start putting that stuff out there, it becomes much more difficult for that like uniform opposition to bully you into silence. So I would say those are two things that can like get your foot in the door to where they're more amenable to your message. And then
Okay.
also meeting on the individual level too beforehand.
And then, Aaron's second part of that question is once they kind of accept
Thank you so
this,
much.
yeah, once they accept this, then,
I'm not
where
sure
do
if I lost connection here, but I just wanted to say thank you. And you think the science, you lead with the science with the doctors as opposed to the personal stories?
I think that um, you know, I'm not sure. I think I would have to think about that one a little bit, because I think that a personal story might go, or like, you know what? Actually, I would do the science first, authoritative comments about the science, right? Like literature, the progression of the protocols from Holland to what's happening in the UK, um, you know, and making conclusion that this is, uh, uh, everything is moving against it. But then you include the personal story at the end. And the reason I say that is because if you start with a personal story in the beginning, I think it would be more likely to turn the pediatricians off, because they're more receptive to like the data in the beginning, because they might think you're like some kind of, like a well, you are an activist, which is good, but like they might be turned off by the perception that someone else is an activist in trying to manipulate them. But if you start with the data first and then go to the personal stories, I think that's better.
Okay. So, Aaron had a second part to that question, which was once they're kind of peaked a little bit, what's the ask?
I think the ask is, you know, I've been in situations where like for my legal funding, right? It's really expensive, and there might be someone who might be willing to donate a lot of money. And the one thing I've learned is you always over ask, because they're more likely to do something. It's like you shoot for the stars, you land on the moon. So I think what your ask should be: are you willing to publish something or speak out and defend this position in a local or national conference? Because those are tangible things that will put their name to the cause, and then like activate them in like a material way. And once people get activated in a material way, like once they have like a role to play, then people like they dip their toes. That's the first thing, but then like they jump in, like cannonball right after that. It's just like once you get those toes in, people like can sense like, oh, the water is a little bit warm. Like then they're jumping in right after that.
Great idea. Great advice. Okay, let's listen hear it from Emmy. I just promoted you to speaker. You should be able to speak now.
Hi.
Yep.
So okay. All right, great. Sorry. Yeah, spaces are just acting so strange today. Dr. Haim, first of all, thank you so much, and thank you, Diag, for holding this fascinating interview. And good evening to everyone. Doctor, first, I just wanted to say, I'm so very sorry for the legal difficulties that you're having, and really, we're behind you, and we're cheering you on, if it can be said that way. We support you, and I'm just hoping for the best of all possible outcomes. I'll be really quick. So I just had one question, and then sort of a very short other question. I was just wondering, do you think we're at the point yet where there's any legal firms that are ready to run those TV ads like you see late at night about, did you go to Camp Lejeune, et cetera, et cetera? Because as annoying as they are, I think in a way they would be such a kind of a blessing, because it would also get the word out there, because you can't help but have this stuff running through your head, and you go like, oh, that's weird. What could be causing, these issues for veterans from Camp Lejeune or whatever. So I'm just wondering if you think we're anywhere near a point where any big legal firm would see that there's enough money in this. And then the other thing, it's really, and this is not to be asking your political affiliations at all. I'm just wondering, with this RFK Jr. Trump alliance that's come about now, do you think that will help at all with this issue for, children health and safety and well-being? And thank you very much.
Yeah, I mean, so thank you for listening. I mean, that's awesome that you guys, stay tuned for this whole time. Um, it really means a lot to us. Like, really, really, it does. It's like my wife and I, we read these comments and we take these things to heart. So it's like what kind of gets us through those really difficult times. But that first point you brought up is really, really poignant. I never thought about that before, but like I do a lot of hernia repairs, right, with mesh, and I would say like maybe 25 to 30% will ask about those commercials. Like, well, are we using mesh? Is it like a different mesh? Is there going to be problems? Like, am I going to have infections? And like, it's something that like everyone has seen. And I think that it would be a really, really effective way to like raise awareness of it. But specifically to answer your question, I think that we're not quite there yet, because I think after maybe the first few cases have been won, I think that it will happen, hopefully. And the reason is because the money to run those ads is massive. So you have these big law firms who make so much money from like these class action lawsuits, who will pay for it because they know that the money they're going to get back in return from these class action lawsuits is going to be really high. So I think that not quite there yet, but I think that's a brilliant idea. I hope someone will do that. Um, and for the second question, yeah, I think that RFK is going to be huge for as a Trump endorsement. And I have a huge, huge amount of respect for RFK because when COVID happened, I read his book, The Real Anthony Fauci, and it opened up my eyes to so many things and so many problems within the profession. And he really is a authority on what it means to to fight chronic disease. And although there's some things I would disagree with him about, maybe particularly like the phone radiation thing, but even that, like because he's done so much research on everything else he said, like I don't discount him offhand. Um, and I think the idea of him being in a Trump administration where he could have a senior role in one of these departments, either number one to metaphorically burn it down, to destroy that department because most of them are completely unnecessary and counterproductive, or to hold these people accountable for all the litany of crimes that they have been committing over the past 10, 20 years. So I think it's really big, and especially because he holds a huge sway with the independent vote.
Thank you so much.
Okay, so we have a couple questions that came up in the chat. You know, one is, don't doctors get training on avoiding the emotional trap of short-term gain versus long-term harm? Isn't that part of the training that
Oh,
should sort
yeah. I
this?
mean, they train us on a lot of things, like it's like if you had like an ethics course in any medical school, lip service would be given to all of this, but the actual practice of it in real life is the complete opposite. Because training in a lecture is one thing, but when the leaders of your profession, when your attendings, like the people above you, when your professors, when all of your colleagues are doing the exact opposite, the pressure to go along is immense. So it doesn't matter what these people are taught in the classroom, and most of what they're taught is complete garbage. Um, so, yeah, lip service might be granted to it in like a theoretical sense, like where you avoid the illusion of short-term efficacy, um, uh, and you ignore long-term risk, but the application of that in real life is uh, overridden by the practice of the authorities within the profession.
Got it. Yeah, it's not enough. Another one is, why are doctors susceptible to being hijacked by an adolescent threatening suicide if they are denied gender gender affirming care? And I've seen this myself, but B, we don't do this with any other threat, right? If a heroin addict said, "I'm going to jump off a bridge if you don't, give me morphine or whatever," no doctor is going to say, "Oh, absolutely, you got us." So why in this case is the adolescent threat of suicide so powerful?
And it's a question I never really thought about, but it's a good point. And it has to do with who is the originator of the blackmail. Like, who is the one who is holding this threat and putting it out there into the world, and then being adopted by these children, which is then being referred back into the clinic. And the reason is it originated with the doctors themselves in order to justify the monumental risks of the hormones and the surgeries. And the reason is because there's they use fraudulent data to support their evidence that this has efficacy. But that's so it's you any critical analysis of these studies shows that they're not worth the paper that they're printed on. You can't make any conclusion from them. So they rely on a certain amount of deception for that. But there is no way to avoid the real expected consequences of the hormones, blockers, and surgery, because that's going to be manifested in their patients physically. There's no way to avoid that. So, in order to overpower the expected risks of these interventions, they have to produce a side effect from non intervention that is so severe that any of these interventions, all the complications, are completely justified. So that's why they use the risk of suicide, because it's one of those things that is the worst possible outcome anyone could ever imagine. If there was any parent who was susceptible to this type of blackmail, right? They have their struggling, nervous, anxious child who's threatening to kill themselves, and you have a doctor who's telling them that all you have to do is these couple of things, then those parents, they're going to do it. They're going to trust that the doctor is telling them the truth, especially when the information about the fraudulence of their studies is not able to be discussed in polite society, especially in professional society. So Um, the reason they have to use the threat of suicide because it's the worst possible outcome anyone could imagine. And I don't necessarily think that it was like a grand conspiracy to choose like the child's suicide. I think it's like the natural logical risk for someone who was trying to like deceive vulnerable people. That would be like the thing you would say. Like if you were to write a novel or like have a theoretical situation, like if you were to really harm these children, but you wanted them to like go along with it and their parents to go along with it, like what would you tell them would be the effect of not going along? Like most of us would probably say, yeah, you just threaten that they're going to kill themselves. And then that's the conclusion that they came to. And of course, what they did is used these statistical analyses, which are easily manipulated, which are used to provide the appearance of legitimacy because they're published in these prestigious journals to give themselves this false sense of credence. But any critical analysis reveals that they're illegitimate.
Yeah, it's kind of that's a real shocker. The logic of it for a clinician, really have a hard time with that. Okay, we've got another question. Wondering whether or not you have seen the video of Jess Ting being horrified by Marcy Bowers cutting up Jazz Jennings. So I guess this is on the Jazz Jennings that uh, reality show. Have you seen that
Yeah.
clip?
Yeah, yeah.
And
Actually, my wife and I watched like all of the seasons.
oh boy,
Just out of curiosity, and yeah, it's very sad. But I remember that episode specifically in that scene.
so so what's your reaction? From a surgeon's point of view, does anything stick out in that clip? Like, is that how surgery goes? Is there anything that lay people might not notice? And just in general, what was your reaction to that clip?
So it's not necessarily uncommon for surgeons to have those kind of encounters in the operating room. Like I would do liver procurements where we have to procure a liver from someone who's recently passed away. And you have the people who are procuring the heart and the lungs, and then we're like downstairs in the abdomen procuring the liver. And this is very like close proximity, like we're talking about a couple centimeters. And it's separated by a vein and called the inferior vena cava. That's where they cut. And I remember an instance where one of my attendings and like he almost he got to like a verbal argument with the guy who was procuring the heart and the lungs about the distance on the IVC. So you can have like these types of encounters where people get like really can get physical in the OR. But of course, it always ends politely, and it's usually just kind of a couple of snippy words. But what was really shocking about that was the nature of the surgery, and then I think Jess Ting was saying like something like all of that is scar, like it's all just scar. And what's so shocking about that is to think about the real estate in that area of the body and to have it just be overgrown with scar tissue and to be operating on that because operating on scar tissue is a nightmare. It's like the worst thing you can do, especially when he had like 3 or 4 separate surgeries because his wound had separated. He had a huge wound dehiscence. So yeah, that was the most shocking thing about it was that he said the thing about the scar that's what really stood out to me, just because my own experience operating on scar tissue.
Yeah, pretty horrific. One last question, then we're going to wrap up. I know that this is being taught in medical schools, that gender ideology is being taught as fact in medical schools, as is kind of the activist, that doctors are supposed to be social justice warriors, not just clinicians. You know, how possible is it to walk that back with these clinicians, both the ones that are in line being trained and the ones who have already been trained with this kind of madness?
I think that the best way to answer that question is to look at other times in history where people have done things that are horrific, unimaginable to their fellow human beings. and what it took for people to walk that back. And what was required was public trials, severe consequences in a court of law, which had then progressed into the court of public opinion. And specifically, what I'm talking about are like the Nuremberg trials. Despite the fact that you had an entire population of Germans, who many of them who had bought into the Nazi ideology, they had fought a horrific war, and then the Allies won, put their leaders on a stand, and publicized it to the entire world. And similar things were done in Japan too, where, like, if you think about Japan before, like during World War II and before that, you had an entire population who was willing to die fighting the Americans. I mean, people forget that on these islands that the Americans were fighting in, like Okinawa, right? Like, you would have people who would die by holding a grenade to themselves before being captured by Americans. You would have families who would jump off the side of a cliff, to kill themselves because they were so scared of the Americans. In both situations, you have a huge group of people who have bought into an ideology so fully and completely. But when you look at even 10, 15, 20 years after 1945, those countries had at least like West Germany, Japan, had turned into like functional countries, right? And especially now, they're what we would call, at least to a certain degree, maybe not as much now with everything with the EU, but it was the act of public hearings, trials, and accountability. Um, of course, these are very different situations, but it's the principle that I think is important, that to answer that question.
Yeah, and that makes sense that it's when this becomes a public issue, when it's not kind of when people actually know about it instead of most people not even knowing this is happening behind the scenes, people will make that change.
Yeah, because we know who the main players are. I mean, they
Yeah.
have identified themselves just like in previous generations. We There's no secret as to who is running this, but the main difference between then and now is there has to be an opposition that has enough courage and enough political will for people to hold them accountable. It's not enough that it stops. Like in the United States, like if it were to be made illegal tomorrow, that would not be enough. It's the people who are responsible for this, for proliferating it, for lying to the public and saying that this is evidence based when it was simply not, when it was based on a political ideology. Those people have to be held accountable to the fullest extent of the law. And though there has to be severe, severe consequences for those people in order for the victims to get justice.
Agreed. Agreed. I think everybody have their list of people.
Yeah.
All got our lists. All right. Well, we're going to wrap up. We've hit the 2 hour mark. I'd love to thank our guest, Dr. Eithan Haim. Thank you for joining us and answering all of our barrage of questions. You can find Dr. Haim on X at his name, Eithan Haim, EITHANHAIM. So follow him there. And thank you for joining us. It's been a pleasure speaking to you. Fun interview. Um, if you haven't already done so, please join DIAG at di-ag.org/join us. Our power to reach our representatives is through our numbers. It's important to show that we are a silent majority who believe in classical liberal principles, following the science, ethical evidence-based medicine for all, the power of civil discourse, protecting the rights of women and girls to sex-based spaces, honors, and opportunities, LGBT rights, and the necessity of a compassionate, reality-based society where truth matters. Thank you all for joining us. Have a good rest of your evening. Thank you again, Dr. Haim.
Yep. And yeah, thank all of you guys for taking the time to listen. You guys are great. Awesome. It was a privilege to be able to speak with you.
Right. Thank you all. Have a good evening.